thank you to all the speakers. We are a little bit in delay, but I think that we can take the question, and I think that it's important to take the questions. We can open this question and answer icon, and let's see what we have. The first question is how to differentiate a sesamoid fracture versus reparted bone on ultrasound.
I can answer you want because
Yes,
I think it was I think sometimes it's very difficult. However, ultrasound information should be taken always in the clinical scenario. So when you have a fracture of sesamoid bone, patients usually have pain. And in addition to that, usually in a fracture, and you will see the surface of the bone profile will be irregular and with a component of inflammation on grayscale or also with Doppler surrounding the bone. And this is not happening in normal bipartite bones. So I wonder if you agree, Dana, and all the our colleagues that
yes,
this is the main tips for differentiating that.
Yes, and it's very important to underline that generally I cannot start my video. I don't know why. Yes, now I can. Generally, when we talking about bipartite bone, we're talking about patella. We don't have bipartite sesamoid. There are two different sesamoid. There are no bipartite sesamoid. Only generally talking about patella.
Yeah, right. Because in the hands we have usually two small. Sometimes you have doubts, and I think the clinical scenario is the most important.
Yeah.
So looking at the second, how can we differentiate by ultrasound the deep involvement in PSA and hand osteoarthritis? Well, thank you for the question. Excellent. We are facing this every day, and sometimes it's impossible because, in fact, it is accepted that there is an overlapping disease, an overlapping between PSA and osteoarthritis. No? In my particular experience, well, there are not so many publications on that. In fact, the publications are accepting this overlapping, but in my personal experience, I would say that in PSA, I can find other typical, we can say no pathognomonic, but typical findings. For example, enthesitis of the extensor of the distal enthesis of the extensor tendon, or in the flexor aspect of the fingers, you can find enthesitis that is not so common or is very infrequent in osteoarthritis, because Sinovitis can be similar in both. So once again, the clinical scenario, the laboratory assessment, and some typical specific findings for PSA, mainly enthesitis, that is are not necessarily so evident in osteoarthritis, can help to differentiate both entities.
Okay, thank you, Esperanza. I think the next question is also for you.
Any role of elastography in Sinovitis?
What is the value? No, Esperanza. What is the value of detection of paratendonitis?
Yes. Sorry. I jump. Yeah. Paratendonitis is the extensor tendon of the finger, and could you show the main role is that it's a very specific finding for PSA. It has been described also in some other arthritis, occasionally in rheumatoid arthritis, early rheumatoid arthritis, and also in seronegative rheumatoid arthritis in elderly. But it's mainly, according to the literature evidence, is very specific for PSA. And how is seen? Well, I didn't include any example because the lecture was so long and was on intra-articular pathology, but the image can be similar to tenosynovitis. So you will see an abnormal hypoechoic material surrounding a tendon with paratino. Example in the hand, the extensor tendon usually is more visible at the level of the metacarpophalangeal joint. So hypoechoic material surrounding the extensor tendon with or without abnormal Doppler activity according to the grade of inflammation.
Okay, I will take the next one. Any role of elastography in synovitis? Are there by predicting recurrence remission? For the moment, we have not enough data about the role of elastography in synovitis. In fact, we have some doubts that elastography it's really useful for synovitis. And when we're talking about recurrence and about active disease, we need Doppler. Elastography, despite the fact that it's soft and not so hard, it's not enough to say that synovitis is active or it's a recurrence. So for the moment, there are not so many data about the role of elastography, strain elastography, or shear wave in synovitis.
Okay, next question I think is for Plamen. What are the ultrasound criteria to diagnose polymyalgia rheumatica?
Thank you, but it could also be for Dana Fodor because polymyalgia.
Yes, thank you. I will
yes, for both, in fact.
Now it's difficult to talk about all ultrasound criteria, but when we have synovitis, bursitis, or tenosynovitis in and around the shoulder or hip, these are in fact ultrasound criteria. And very important, we have to verify the bilaterality of this lesion. But there are published these criteria and very well described. So look at the shoulder, look at the hip, and search for fluid in joint, in tendon sheet, or in bursa. Thank you. But the next one is for you for sure.
I just wanted to add for the shoulder in polymyalgia rheumatica that there's some data that maybe it's not so symmetrical as you said, maybe it's not so
symmetrically, but you have to need symmetrically.
Yes, and maybe bursitis is more common, but okay, thank you. So the next question.
The next question is for you, Plamen.
What is it?
Can you see the chat? Chat. So, sorry, questions and answers. Questions and answer.
Okay, just a second. This is for the okay. That was this. The question is it only the associated diffusion in the glenohumeral joint which differentiate biceps tendon sheath diffusion from the tenosynovitis, or is it also important to detect tendon thickening or power Doppler to consider it as tenosynovitis? Okay, from our team literature search, that would come that if we don't see, because as you know, anatomically biceps tendon sheath is just a prolongation somehow of the joint capsule of the shoulder, but when you don't see also a fusion in the glenohumeral joint or synovitis, you can consider it a separate entity, and also tendon thickening will be more for tendonitis or tenopathy of the biceps tendon, which is not infrequent disease. And power Doppler, of course, you can see it when, as with all tenosynovitis, when the disease is active. Thank you.
Okay, thank you, Plamen. Next question is for Dana for sure. While scanning the quadriceps tendon for enthesitis design, especially thickening, where do we, sorry, for Plamen too, sorry. When do we exactly measure, if necessary, or we can discuss that?
Like I would like to answer, but like with all entheses, we usually measure the thickness perpendicularly to the direction of the tendon fibers at the place where the deep margin of the tendon meet the corresponding bone where the tendon inserts in this site, the quadriceps tendon, the inferior margin of the quadriceps tendon when it meets the patella, and perpendicular to the direction of the tendon.
Nevertheless, I would like to point out that sometimes it's not necessary, because the criteria is more when you see a thickening of the enthesis as compared to the body of the tendon. So not necessarily you need to take a measurement, because if
you can compare.
Clearly see a thickening as compared to the rest of the tendon, it can be considered an accurate sign of enthesitis.
This is an ongoing debate whether we need to measure or to compare.
Yeah, no, it is a long discussion.
Yeah.
Okay. So next one,
Please.
calcific
for you too,
tendonitis of the iliotibial band insertion in a patient with high uric acid levels is suggestive of gouty involvement. Well, the iliotibial band insertion at the Gerdi tubercle maybe is a site of huge mechanical stress, and probably this calcific tendonitis will speak more about some overuse syndrome like runner knee or something else of the, but maybe the high uric acid levels will point also to gout, but not specifically this calcific tendonitis. So this is at least my interpretation.
It's possible, but it's rare.
Yes.
Or it's not impossible. Okay, Plamen, we are back to polymyalgia rheumatica. Another question for you.
But we have also already discussed this, but for the second part of the question, how to differentiate polymyalgia from adhesive capsulitis. So polymyalgia rheumatica is an inflammatory disease, while adhesive capsulitis is more with structural changes. So in polymyalgia, we'll have bursitis, suprachromial subdeltoid bursitis, usually interarticular, also effusion in the posterior recessus or axillary recessus, and also tenosynovitis or effusion actually in the biceps tendon sheath. While in the adhesive capsulitis, we'll see thickening of the capsule where we can measure it, and this is particularly the inferior capsule or the coracohumeral ligament, and we can see some hypoechodyspnea in the rotator interval, but also the adhesive capsulitis usually will have only one side, while the polymyalgia will have on the both sides, and more importantly, we'll have also hip involvement. Thank you.
And to add that there are dynamic examination which establish the diagnosis of capsulitis.
Yes.
No problem in polymyalgia.
Never forget the
and no
dynamic.
Movement and the dynamic.
Okay, thank you. Next question I think it's one, the next two questions. So I think it's for Path. Any study where ground plate dimensions are studied using ultrasound? I suppose in breast injuries or other pathologies?
Paz, open the microphone.
Okay, okay, of course, sorry. I'm trying to answer both. Really, there is no specific studies regarding the growth plate dimensions, and even the only studies that they are published are regarding the cartilage dimensions. But not exactly the growth plate. You have to consider that the hyaline cartilage is part of the growth skeleton, but there is a small part between the hyaline cartilage of the distal bone and the metaphysis. Between both, there is a growth plate, and there is no specific studies, but yes, there is about the dimension of the cartilage and regarding the age and regarding the gender. It was published, but German, I don't remember the name, sorry, but there are two studies very nice, and actually in the group of German is managed by Daniel, is working about the ossification, the different grade of ossification, and they are measure the dimension of the cartilage regarding the age and the gender. So
okay, thank you, Paz. And the last question for Jacqueline. Please, Jacqueline, take the question.
Well, thank you. Thank you. Can you hear me?
Yes, we can.
Okay, okay. Hello, everyone. If we can, of course, we can investigate pathologic tissue periarticular. You mean synovial tissue of a synovial tendon, or you mean in soft tissue? In I don't know, actually know exactly the question. It could be soft tissue also, in the subcutaneous tissue. It could be also in muscle tissue. Of course, this all depends on the dexterity of the skills of the ultrasonographer. No, it's skills in performing ultrasound guided biopsies. I don't know if anybody has any more questions, but it can be done, of course. And as we get better biopsy guns, and we get better skilled, we will be able to obtain probably better samples, more samples, and samples of better quality, because that has a lot to do when you obtain your results, especially when one is studying a patient with chronic arthritis. When one wants to rule out, let's say infection, that there is a lot of infection, and there can be infection in patients with inflammatory arthritis treated with biologic therapy around the soft tissues. Also, we could do that, and that probably the yield is higher for this. But actually, we lack publications. I think this in hands of rheumatology is really we're at a starting point with this.
I think, Jacqueline, maybe you agree with me that possibly the most challenging periarticular biopsy should be tenosynovial, because it's a very small space. We need a very thin needle, but at the same time able to take representative samples for studying microbiological or whatever.
Yeah.
And then without damaging the tendon. But now some groups are training on that. I think in the near future we'll have enough thin needles to do that without any damage or any risk for the patients. You agree?
Mm.
So it's much more difficult than intrarticular synovial biopsy, obviously. But it's still feasible if the technology is improving with the needles.
That's right. That's right. That's the needles. We just need people to investigate in it.
Yeah. Exactly. And no, the manufacturer to produce.
Yeah, that's right.
Appropriate needles for that, because the current needles are maybe too thick for a tenosynovial teeth. I think we have another one question.
Yes, there is. I think that is for Plaman.
Yes, thank you. Any row for ultrasound regarding patellofemoral instability? So I checked but in our review of the literature, there was not enough ultrasound data for these clinical conditions. Anyway, distorted or ruptured medial patellofemoral ligament or patelloadductorial ligament could be visualized by ultrasound, but this is in case of dislocation mostly of the patella. But in the patellofemoral instability, at least I don't have the data. If some of the colleagues can help me with this, please.
No, I agree. There are not enough data. There are not enough data, but we can try to see. We can try also to measure the angles of the femoral condyle, but it's much easier to use other imaging techniques. Okay, thank you. I see that there are not other questions. So it means that we are at the end of this meeting. I think that it was a nice meeting, and I hope that all the participants have something to gain, have something to learn, and I am very happy to be here with you, and to thank you to everyone to be here today and to be involved so active in our project with EFSUMB guidelines and recommendations.
I think that the paper on these recommendations, guidelines will be hopefully published very soon, and everybody can read
I hope
all the things we tried to say it in a very short time. More.
Yes. Yes, as I already told you, 900 of references.
Yeah.
Work when I add the first part to the second part, and I saw that there are 895 references. Huge work. Excellent team, in my
200
opinion.
only for the shoulder.
Yeah.
Okay.
Thank you very much.
That's right.
Stay healthy.
Thank you very much.
Thank you very much,
Thank
Lana.
you,
Enjoy a lot.
gentlemen.
Thank you,
Bye.
everyone.
Thank you, everyone.
Thank you.
Thank you.
Enjoy.
Welcome.
Thank you, EFSUMB.